Hey, future PTAs. Today we're going to talk about the brainstem and the cranial nerves. So the brainstem is broken up into three regions: the midbrain, the pons, and the medulla oblongata. The midbrain contains the red nucleus. This is responsible for motor coordination, primarily of the arms. The substantia nigra is also in the midbrain. That makes dopamine and is connected to the basal ganglia. The superior colliculus connects the eyes to the cranial nerves that move the eyes, which several of the cranial nerves help with that. And then the inferior colliculus connects the ears with the auditory centers of the brain. So the midbrain has a lot of connections between different portions of the brain. Cranial nerve 3 is the oculomotor nerve, one of the ones responsible for moving the eyes that the superior colliculus connects to. And then cranial nerve 4 is the trochlear nerve that is also responsible for moving eyes. They're both found in the midbrain, connecting there. Since we just talked about the substantia nigra, where dopamine is created, or let's see, dopamine is, made there. So I just want to make sure where I said it. Dopamine is a neurotransmitter. It helps with movement. When there is too little dopamine present, it's as if the patient's muscles are constantly getting an inhibitory signal. So they're constantly being told stop or relax. And so it's really hard to initiate and make big movements because there's constantly a signal going out for them to stop the movement. So if their brain is telling their body to do this big movement, it's going to take a while before they start to do the movement, and then the movement is going to be diminished. It's going to be a smaller movement because the inhibitory signal is constantly being sent out throughout their body. Parkinson's disease is a result of death of the dopamine producing neurons in the substantia nigra. So the dopamine levels are low because so many of those neurons are dying over time. Typically, you don't see signs and symptoms until 80% or more of those neurons are already lost. So by that point, it's really late in the game, even though it's the beginning of the symptoms of the disease process. Some of the symptoms are resting tremors, like a peel rolling tremor where they'll move their hand like that. Bradykinesia, which is like slow movements, and then postural instability, like that stooped posture, a real rigid posture, doll face. They don't make a lot of facial expressions, a forward trunk lean. They often have also a lot of problems with their movement, of course, but especially their gait. So they'll have like a shuffling gait and a freezing of gait where they'll stop mid-movement. There are some medications that can treat Parkinson's disease, and they either replace some of the dopamine that's missing, or they can augment some of the effects of that missing dopamine. The pons is another portion of the brainstem, and it contains cranial nerves 5 through 7. It has a lot of connections to the cerebellum, which remember is like our balance and coordination centers. It also has nerve fibers that connect the brain and spinal cord for voluntary movement. So if the pons is damaged, it could cause locked-in syndrome. So sometimes the pons can be damaged by a basilar artery infarct, like a stroke in the basilar artery. Or if the basilar artery is compressed after a car accident, then it could also cause damage to that area. So what locked-in syndrome is where the motor neurons only are selectively damaged, and it causes complete motor paralysis, meaning no movement of the face or any of the limbs. However, the sensation throughout the entire body is intact, and the patient is still alert and oriented, and is still able to move their eyes. So they still hear and see everything. Their brain is still fully functioning. They still feel every sensation throughout their body, but cannot move. Really sad state. And they have came out with some communication devices that are controlled by either blinking or eye movements, and so that the person is able to to communicate some, which is one of the reasons we know that the brain is fully intact and they're fully aware of what's going on around them. The medulla oblongata. So another part of the brain stem, it connects the brain and spinal cord. It also contains the dorsal respiratory nucleus, which controls your breathing. It contains the inferior olivary nucleus, which detects movement and may help with motor learning. And if this area, the dorsal respiratory nucleus, gets damaged, it causes immediate death because you cannot breathe without it, not even on a machine. All right, so these are some of the brainstem tracks. The ascending ones go from the parts of your body up to the brain, and so they give you that sensation. And then the descending go from your brain down out towards your body to give you movement. So all the ascending tracks are sensation to tell your mind where your body is and what's going on with it. And all the descending tracks are all movement to allow you to have those movements. So they're motor. So the ascending, some of them include the anterior spinal thalamic, which allows you to feel light touch and pressure. The lateral spinal thalamic, which allows you to feel pain and temperature changes. The dorsal column allows you to determine 2-point discrimination. You know, am I touching you here or here? Vibration and proprioception, so that where your body is in space is sent through that dorsal column. And then the spinocerebellar gives you that unconscious proprioception, like posture muscles, things that you're not clearly thinking about, but your body is getting input about. Then the descending tracks are the lateral corticospinal, which helps you move the opposite side of the body. The reticulospinal, which inhibits muscle tone, so keeps you from having that spasticity or staying in a synergy pattern stuck in that movement. And then the vestibulospinal helps with balance and posture. The reticular formation is kind of the core of the brain stem. It is involved in motivation and decision making, in your mood, your sleep wake cycles, and in pain modification. So the ARAS, the ascending reticular activating system, sends sensory input from the body to the thalamus. The sensory input provides conscious awareness, and damage to the reticular formation can lead to a coma. So, in the book, it talks about a coma being defined by the eyes being closed. Once the eyes are open, if they still are not reacting to the environment, they're still not, squeezing your hand to commands or following any type of commands or doing like their own intentional movements, then it can be considered a vegetative state. So their eyes are now open, but they are still not responding to their environment. It's a vegetative state. So now we're going to move on to our cranial nerves. So these provide all the sensory and motor innervation for the head and neck. Cranial nerves 1 and 2 can be considered part of the central nervous system because they of their location, where they're located. But typically we consider all of them the peripheral nerves. So in general, if it asks about cranial nerves, they are peripheral nerves. They're not central nerves. Central nervous system is just your brain and your spinal cord. But 3 through 12 all emerge from the brain stem, and that is why they're very obviously peripheral nerves, whereas 1 and 2 kind of bridge right off of the brain and are not as obvious to categorize. Cranial nerve 1 is your olfactory. So it detects and transmits odors. It connects the olfactory cortex in the temporal lobe and the amygdala. The amygdala is that part of the limbic system that is responsible for your emotional and visceral responses to odor. So if you smell something and you're immediately disgusted, or you smell it and you're like, ooh, that's kind of nice, that is the amygdala. And it is also responsible for connecting the thalamus for the connections in the thalamus are responsible for causing salivation and or nausea in response to odors. So all of that is related to that olfactory nerve or cranial nerve 1. The loss of the sense of smell is called anosmia. It could be caused by damage to the olfactory nerve, either if they have like a tumor or an infection, if it's been, if there's been some trauma there. Um, Temporary anosmia can happen when mucus just blocks those olfactory cells and neurons from being able to transmit that information. Typically, once the mucus is gone, then it clears up. Olfactory cells are also lost with age. They decrease more and more over time as we age. And our sense of smell gives us a lot of information about the taste of food. So as our sense of smell is diminished, as you've probably noticed when you have a cold or something, you cannot taste food as well. So as people age and they have a decreased sense of smell, they also have a decreased sense of taste. One of the good things is olfactory cells are one of the few cells in the body that can regenerate, so it could come back even if they're damaged. But anosmia, the loss of sense of smell is one of the early signs of a degenerative brain disease like Parkinson's disease. So sometimes some of the earliest signs is not being able to smell. All right, our optic nerve detects and transmits our visual information. It does not regenerate. So if it is injured, then whatever loss there is going to remain. Inside of the optic nerve, there are rods and cones. The rods are responsible for your black and white vision, especially like your nighttime vision. Your cones detect color and give you a lot more vibrant details of vision versus rods are almost like big picture, like what you see at nighttime. The optic nerve converts light into action potentials, and those are sent along the neuron to the brain to be processed as your visual input. Sometimes the optic nerve can actually not the optic nerve, the retina can actually be damaged in premature babies. They often have underdeveloped lungs and are given oxygen to survive. If too much oxygen or the pressure of the oxygen is too much for the baby, if too much is given, then it can damage the blood cells to the retina and it can cause them to rupture and cause blindness due to retinopathy. So that's just something to think about with the optic nerve. Oculomotor, cranial nerve 3. This helps with eyeball movements. It also helps with voluntarily opening the eyes and with pupil constriction and changing the lens shape to focus on nearby objects. So if you look far away, your lens is one shape, and then when you look closer, your lens actually changes shape to help you focus on something that's closer. The oculomotor nerve does all of that. One thing that can happen, it's actually pretty vulnerable to compression if there is any swelling or bleeding in the brain. So if you have some type of a brain injury or a brain trauma, that swelling or bleeding in the brain can push on the oculomotor nerve and cause damage to it. So one of the signs of ocular nerve one of the signs of brain damage is ocular nerve palsy. So if the pupils don't constrict when a light is shining in them, then that is a sign that the oculomotor nerve is damaged, most likely due to brain swelling or brain bleeding. That's why after a traumatic injury or after like a concussion, if somebody, hits their head during a football game or is in a car accident, and then the trainer will come and shine a light in their eye and look to see if the pupil constricts. If it does not, that's a bad sign. It's often one of the first indicators that there is neurological damage and they need to, go to a hospital and be checked out immediately. Cranial nerve 4 is trochlear. It also helps move the eyes, but specifically it helps them move down and in, like you're looking towards your nose. And damage to that nerve could cause double vision. The trigeminal nerve, cranial nerve 5, is responsible for sensation to the face. It's also sensation to the mouth and the scalp. It also helps control the muscles for chewing and the muscles inside the ear that contract to prevent damage to the eardrum. So, trigeminal neuralgia is when the trigeminal nerve has been damaged. It's a very painful condition. The damage might happen because of swelling in the area, or it is often damaged in patients who have multiple sclerosis. This causes severe pain, typically around the jawline, and that pain can be triggered by very basic everyday activities like just basic soft touch to the face, yawning, chewing, brushing the teeth, anything like that can trigger that severe, intense pain that people often describe as like a hot poker or a zinging, like a nerve pain. And this pain can be debilitating. Abducens cranial nerve 6 helps with the lateral eye movements, and damage to this nerve can also cause that diplopia, which is the double vision. The facial nerve helps with facial expressions. It produces tears and saliva and helps you with taste. So, damage to the facial nerve is called Bell's palsy. It causes paralysis of one side of the face. It also causes that eye to not be able to blink, to close, and your tear production is stopped on that side. Your saliva is stopped on that side. It's harder to taste on that side. So oftentimes if somebody has Bell's palsy, their eye will get really dry and irritated because not only can they not close it and blink, but they also can't produce tears on that side. Um, this is often caused by just a basic infection that causes swelling in the area and compression of the facial nerve. Around 80% of these cases typically resolve within the first 8 weeks without any medicine needed. So there are some medications that could, like steroids and things, that could decrease the swelling in the area and help it resolve. But some of the cases never resolve and cause permanent damage. That damage, again, is really, it can be really debilitating in itself because of the lack of ability to blink and produce tears and the production. It may make it hard to eat. Facial rehab can sometimes help restore function, depending on if there's any impulses getting through with that nerve at all. The vestibulocochlear nerve helps with balance and hearing. The glossopharyngeal nerve, cranial nerve 9, helps with sensation to the palate, the pharynx, the ear, the tongue. It also helps with that gag reflex. And interestingly enough, it helps control heart rate and blood pressure. Also, it helps with salivation and taste. So, glossopharyngeal, I always think gloss, tongue, helps with the tongue, the salivation, taste, gag. And then I have to put heart rate and blood pressure because they feel like they just don't go with all that. Um, but that is responsible for that as well. The vagus nerve, it helps slow the heart rate down and decrease the contraction force of the heart. So it is like rest and digest is kind of how we usually remember with the vagus nerve, that it'll slow the heart rate down to rest, helps you digest, swallow, helps with speech. And it also can create that taste in the back of your throat. So like sometimes when you're sick and you're having like, I have this weird taste in the back of my throat. It's probably the vagus nerve that's telling your brain that. Cranial nerve 11 is your spinal accessory. This to me is the strangest cranial nerve because all it does is innervate two muscles, the sternocleidomastoid and the trapezius. These all help with neck movement, so it's understandable that they're innervated by cranial nerves, but that's all it does. It's just the two muscles there, SCM and trapezius. Last cranial nerve 12, is the hypoglossal nerve. Damage to this can cause paralysis of the opposite side of the tongue. It could cause that side to atrophy and start pulling towards that side because of the atrophy. So the injured side, it will kind of pull towards that side. There are some brainstem reflexes that's useful in assessing cranial nerve function. It's not something PTs do very often unless they're assessing for maybe a um, concussion or something like that. But the pupillary light reflex I already talked about, you shine a light in one eye and watch the pupil constrict. Really important in determining if there's some brain damage that needs to be looked at. Cornea blink reflex is another. There are different reflexes for each many of the cranial nerves, but I don't expect you to know them for that class. It's just kind of a little extra information to be aware of. So I will see you in the next lecture.